Good afternoon, everybody. Welcome to the latest MTech Access Words of Wisdom webinar. Every month we're bringing you insight from senior leaders across the NHS to help you stay connected to the change that's going on. We'll be getting to grips with the NHS, exploring all the challenges our guests face, how they may respond to them, and more so what the future is going to look like as various political and strategic agendas develop. And the idea is all about connecting you with people who are driving change in the NHS. This month, I'm delighted to be joined by Dr John Ribchester, who is the Clinical Director of Whitstable Primary Care Network. John is a bit of a pioneer in primary care, has spearheaded lots of new initiatives and different ways of doing things, I suppose. We're going to explore a few of those today, and is a really insightful guy to be speaking with today. So thank you very much for joining me, John. For everyone in the audience as well, there are hopefully on the right of your screen some handouts which are summaries of the NHS or of the governmental white paper on the changes to the NHS, in case you haven't already seen them, so feel free to download those. So John, welcome this afternoon. Thanks for joining us. For those in the audience that don't know you, could you just quickly summarise your organisation and your role?
Yes, thank you. Good afternoon. I'm executive partner of the Whitstable medical practice, which pioneered the concept of primary care networks along with other so-called MCPs. When Simon Stevens first came to power, he suggested that we ought to be working in bigger groups than ordinary sized general practices, roughly 10,000 patients, and new care models were promoted and a 3-year trial was done. We, along with other medical practices, formed the Encompass multi-professional community provider, and the proof from that was used to inform the development of primary care networks. So Whitstable is now a single practice primary care network, which has certain advantages we can explore later, but it was an easy transition for us to try to carry on with what we were already doing, which was providing hopefully high quality general practice alongside local care, local health and community care.
Yeah, fantastic. Thank you very much. And like you say, there's already in that one sentence, there's huge amounts for us to explore, I think. Before we get into that, you joined me all the way back in June and we talked about the impact of COVID on primary and community care. Could you just catch us up in the 8 months since? What's changed in primary care? What have you seen?
Well, it's been a huge challenge for all of us, principally with ordinary GMS services. Everything now starts with a remote consultation. So it's either by good old-fashioned telephone or by video consultation. Only then is a judgment made about whether a patient genuinely needs a face-to-face contact. And in addition to that, e-consultations are part of the landscape. Previously, only the enthusiasts were interested in that. I think we're all doing that now. Actually, within our buildings, we are having to implement social distancing for staff and patients. So there are 3/4 of the chairs are missing now, and small numbers of people are in a socially distanced way, and we are trying to maintain that business as usual, if you can call it usual, alongside COVID specific issues, and that includes the pulse oximetry at home for people who are positive for COVID but aren't ill enough to need to be in hospital. They self-monitor for a fortnight and we receive the results, and if the oxygen levels go down, then that's an early warning to get them into hospital before they feel breathless. And the other thing that many PCNs are doing, us included, is COVID vaccination program, and ours is, I think I'm right in saying, the only drive-through COVID vaccination site in England, and we are vaccinating 100 an hour up to the number of vaccines we receive. Currently we get 1 or 2 deliveries of 1,200 a week, so we're doing up to 2,500 a week in our drive-through.
Have vaccinations taken over completely in the last couple of weeks, or are you still doing a fair amount of?
We seem to be either getting 1 delivery of 1,200 or 2, alternate weeks. So you know, we're just slightly ahead of the target, and we are now on the second wave of extremely vulnerables between the age of 18 and 65. And we've done all the care homes. That wasn't supposed to be our job, we've done them anyway, and health and social care professionals, and everybody down to, we're about age 66 now, we're down to, and we're going down in date order, and the vulnerable groups, as I've said.
Are there people that you're not seeing at the moment that you think you should be?
I got that, thank you. Yes, I mean, that's a concern for all of us, I think, that people aren't presenting with non-COVID symptoms. Two reasons, really. Some people feel they don't want to bother the doctor. Other people want to stay away for fear of catching COVID. So that's a concern for us, and it's a concern for our hospital colleagues as well.
Yeah, okay, thank you. I'm hoping that my mic's going to stand up to this. You've talked about some of the change that you brought in, that you've done things differently out of necessity through COVID. What of those sort of operational changes are you hoping to keep as we come through the pandemic?
The operational changes we will probably keep to a large extent is the concept of starting with a GP or nurse triage with a remote consultation. We've discovered that this actually works for a much greater percentage of people than we previously thought, and also quite a lot of patients enjoy it because it's much more convenient than having to drive to the surgery, and it's much more accessible. You know, by and large, people will get a remote consultation within half a day of when they ask for it, whereas a GP appointment might be a couple of days ahead, unless of course it's urgent, in which case that'll be immediate.
Yeah, okay. And certainly my experience in primary care of bringing these new types of working in the past has been kind of a mistrust, or a possibly through a lack of understanding, and that I think that perception that if you're not seeing someone in the room with you, you're not getting all the cues, all the information. Do you see any downsides to that remote consulting way?
Yes, indeed. I mean, you do pick up something by just observing your patient, almost subconsciously when they come in. Do they look slightly thinner in the face? Are they anemic? Are they jaundiced? You can't really pick that up in a remote consultation. Unfortunately, face to face, it's not as easy either at the moment, because of course we're all masked up, and to pick up psychological cues about how someone's feeling when they're masked up is a bit different. You know, difficult. You may see a few wrinkles around the eyebrows or the forehead, but you can't pick up the whole facial expressions.
Just picking up on that idea around the white paper that came out last week, and that's indicated direction of travel for the NHS. What are your reflections on some of the things within that white paper?
Right. Well, it's really a lot of it's more of the same. I mean, it was announced at the very beginning that we were going to have a move towards, from small cities to large cities, CGs were going to become ICS, and that is in fact what's happening. So there's nothing new about that. The concept of the Secretary of State having more influence over major decisions such as hospitals being created or destroyed, again, there's nothing really new about that either, because he can do that now. So I suppose a lot of us are thinking, is this just another illusionary piece of progress? Because we get this every so many years, the NHS reorganizes itself. You get stasis with regard to making any clinical progress, while everyone gets new names and new positions, and then maybe a year after that you might get back to making some clinical change. So I think some of us who have been around for a while, such as myself, are a little bit skeptical that there's going to be an awful lot of change.
Yeah, okay. So over the last couple of years, we've heard various noises from within the NHS saying that no real change would happen without legislation. Now legislation has been suggested. Do you think actually it is an enabler? I mean, you've obviously been doing some of the integrated working for some time now. Does this really make a difference to you in practice, the legislative element?
I think the worry for primary care networks, which are described as a building block for the new NHS within ICPs, that's integrated care partnerships, and then an overall integrated care system. The worry is that the PCNs have got no influence. They've got no tools with which to do the job. And going to your point about legislation might be good if it gave PCNs a percentage of the patient budget for acute care and chronic care as well. But at the moment, we've got none of that. And neither do the CCGs have much money, certainly in our neighbourhood. And also, they don't seem to have the ability to wire money from acute trusts into primary care networks, which is a terrible shame, because the main reason for primary care networks is to develop local care and take those services out of hospital into the community, where we've been able to prove through the new care models you can get better care closer to home at less cost. But unless there's any funding at all, you can't really start. And I think a lot of PCNs are finding this frustrating.
Okay, so what's the secret going to be to transferring that budget? Is it simply the case of someone at a central level saying money's going to be here rather than there, or is there something that PCNs need to do locally in order to kind of earn that trust, as it were?
Well, the best that can happen is that we can work with acute trusts and develop local care systems and new pathways. I mean, there's no reason, for instance, why fracture clinics should exist in a hospital. They can exist in the community where you have X-ray, as we do. There's no reason why DVTs should have to go to a hospital. That can be treated locally where you have a D-dimer blood test and ultrasound, again, like we have. Many of these things can be developed to the benefit of the patient, which is probably the most important thing, surely, but also to the benefit of the system, because it's faster and it's less expensive. And similarly, with a network of consultants working with GPs with special interests, who now appear to be called GIFers, GPs with extended roles, if we can do that properly, a lot of what goes to outpatient departments doesn't have to go there. And if you have PCNs with either outreach clinics with consultants, with or without GIPers, and the necessary diagnostic equipment, we could do so much better than the very hospital-centric, expensive system that we currently have.
Yeah, fantastic. Thank you. And obviously, you've got really good experience in leading some of these initiatives, taking some of that care into new settings. How do you get to that point? How do you sort of prioritize those things? How do you come to agreements locally about which areas to focus on?
Well, we've worked through about 5 different incarnations of NHS management, starting off with PCGs, then PCD, PCTs, then CCGs, and now integrated care partnerships. And I think the important thing is to have the enthusiasm and the vision to actually want to develop integrated care. And I'm fortunate, and I work in a good team where that really is the vision, both for urgent care, in that we run an urgent treatment centre with fracture clinic and DVT service and X-ray 12 hours a day, 365 days a year, but also in elective care. And we have a range of outpatients, diagnostics and day surgery, including cataract and dermatology. And there's a huge enthusiasm within the practice PCN that I work in to do all of this. It also makes for a huge amount more job satisfaction, both for doctors, nurses, paramedics, and the ARRS roles, because you can do so much more and complete whole patient journeys rather than have to refer patients in large numbers for simple things like diagnostics or basic outpatient appointments. So a lot of job satisfaction, huge amount of patient satisfaction, and in my way of thinking, integrated care is the way forward to keep general practice sustainable. However, you do need the enthusiasm, and you've got to keep pushing on doors that don't open immediately.
Yeah, okay. And you mentioned in your introductory comments, and you referenced it just there, the importance of being, or from your perspective, the importance of being a single practice PCN. Can you just give a little, sort of expand a little bit on that? And do you see that as an evolution of primary care, that there will be more of these sort of super practices or single practice PCNs emerging?
Yeah, I think it's a very relevant point, because my colleagues who I speak to on a daily basis, who are in PCNs with 2 or sometimes many more general practices, struggle with joint employment of clinicians and managers. They struggle with how to apportion the time of people in ARRS roles. You know, how much of the first contact, pardon me, first contact physiotherapy do you have? How much do I have? And also just trying to get everyone pulling together in the same direction with the same strategy is a real problem if you've got 2 or 3 practices who aren't thinking exactly the same as each other. I unfortunately get quite smug that none of this comes anywhere near us. You know, we are one practice with a management team that we elect with clinicians working alongside very good specialist managers. We don't have to worry about who has the ARRS roles, because of course it's one practice, and all of the accountancy and VAT issues, they just don't appear. And I think we are seeing up and down the country practices combining into bigger and bigger units, and I would predict that there'll be many more single practice PCNs as time goes on.
That's really interesting to hear. And thinking about sort of that practice, sort of the optimal practice size for PCNs of 30 to 50,000 patients, or at least that's the theorized size anyway. Do you think that is a good size population for you to be managing? Does it feel like a manageable size?
Well, yes. I mean, we've been 40,000 for a good many years now, and with 25 GPs, we have a staff of 200, including the clinical and non-clinical, many of whom are part-time, I should add, and it works very well. And you're big enough to actually have your own in-house education and training systems. You're big enough for many of the services I've been mentioning to actually effectively refer to your own organization. So the commoner outpatients, diagnostics, etc., you can have enough patients to make those clinically effective and cost effective, but at the same time working with your colleagues in neighboring PCNs. So we provide X-ray, ultrasound, echocardiography to probably about 200,000 patients, although we only have 40,000 of our own. We provide a cataract service to about 150,000 patients, not our 40,000. And I think you can cross-collaborate like this with other PCNs once you've got enough of a base to do it yourself. And although it feels somewhat worrying to invest in all this equipment and these personnel at our size, think how much more difficult it must be if there are 3 practices who have only recently come together, investing their own money in something which they then have to share, and they perhaps don't know each other well enough to have the confidence to do that.
Yeah, absolutely. Yeah, and certainly my own experience of some of the new roles coming through, physicians associates, clinical pharmacists, for me it's a couple of years out of date, but we had lots of those conversations about, can we have 0.6 of a role, 0.2 of a role, how much do we need? For you working at that level, is it much more a case of, well, absolutely we can fill that person's time, it's really a case of where best we use them, rather than how are we going to keep that person busy?
Yes, it is. I mean, it's quite easy to be competent to employ them, and to, you know, have developed clinical pathways. We have a weekly educational meeting, or we did before COVID anyway. We're now trying to do it virtually, and all these clinical pathways can be discussed between us and agreed and then reviewed, and that seems to work very well for us.
Yeah, fantastic. What you've mentioned in there about how you're working with other PCNs locally to serve bigger populations. And one of the emergent themes in the white paper, well, I say emergent themes, that you've referenced it already, it's been around for a while, characterized as place in the white paper, and formally integrated care partnerships, sort of interchangeable terms, which is somewhere between a PCN and an integrated care system. Can you sort of underline your understanding of how that kind of intermediary level place integrated care partnership will work in practice in terms of local organisations coming together?
I think it's a challenge. I mean, as a PCN, you can develop your strategy, you can develop your 5-year view and know what your local population wants. I mean, we're all encouraged to do population health management, and I think either informally or formally, those PCNs that are feeling confident are doing that, and you know what you want. The minute you start working at a larger scale, there are some things you have in common. For instance, you may want to do better diabetic management, but you may have a specific passion for developing, for instance, a hysteroscopy service, which isn't shared by your colleagues. So I think it's really, it depends on the size of the project and the necessary patient base, what level you think at. You know, some projects can work at PCN level, others need more patients referred in, so you have to work at several PCN level, several PCNs together levels, and then you might get up to ICP level for the bigger issues like, for instance, diabetes or mental health. So it depends just what the clinical initiative is, what level you have to think at.
So is it almost a bit like a kind of a funnel of however many patients you've got, the initiative will kind of stop at the right part of the funnel, if that isn't a too crude a way to put it?
Yes, I think I hear what you're saying. You know, what is the need that for the project you're thinking about? If you can afford to buy in the specialist staff, whether it be doctors or specialist nurses for that, and afford the equipment at PCN level, that's fine. But if you're talking about, for instance, a cataract service where you might want £300,000 worth of equipment, and you are going to want to probably do about 20 a week, the maths dictates that you have to work with other people or be sure to get referrals in from adjacent PCN.
Yeah, okay. And you talked a bit about the scale of your practice, your PCN, being able to do a lot of stuff in-house. You mentioned education training, the management capabilities, as well as the clinical side of things. Are there any things that you'd like to do in-house that you're not currently, or that maybe you've got planned?
There are several other clinical initiatives we'd like to get going, but partly because of COVID and partly because of the rather difficult contracting and procurement process before it, we haven't been able to get going. There is a reluctance for acute trusts typically to release funds to let someone else do what they're doing, even if the someone else can do it more clinically efficiently and cheaper. And this is one of the shortfalls of the NHS, really. The acute trusts tend to get most of the money and most of the influence. And this is a bit of a barrier, I think, for developing local care. You know, we all know it makes sense. We all know that the most expensive place to deliver services is within a hospital. So both clinically and financially, it makes sense to develop local care, which is what the new NHS is supposed to be about. But trying to get traditional providers to relinquish the funds in order for it to be provided better elsewhere is a major problem.
That's a really interesting point, and you mentioned earlier population health management as well, and I wanted to come back to that. I think at a system level, kind of population health management makes sense, and I think that the theory behind it, everyone kind of seems to throw their weight behind. At a practical level of running a PCN or in primary care more widely, what does population health management actually mean to you?
I was rather hoping you weren't going to ask me that, because no one can answer that question. There's umpteen definitions of population health management. Yeah. I think what it really means is meeting the needs, in particular the unmet needs of your local population. And to give you an example, I mean, our practice, we have 25% of people over 65. We're very much looking at improving long-term condition management. 8 miles down the road, there is the university practice. They haven't got anybody over the age of 21, and that's a bit of an exaggeration, but you know what I mean. You know, they don't have anybody over 65. Their unmet needs are completely different to ours. They need psychological services, they need addiction services, they probably need better contraception services. So their population health management will look totally different to ours, even though we're actually adjacent practices.
And do you, or I suppose, have you felt historically enabled to work differently given the sort of contractual landscape of primary care? And do you think that you will be given additional abilities to kind of diversify, if you want, from how other practices work?
Yeah, I'm nervous about that. I mean, when we were a new care model, the Encompass MCP, we actually stepped outside of the normal, you know, contracting, commissioning, procurement route, and we were able to develop multidisciplinary teams. We started employing paramedics before they became part of ARRS. We had more of a free rein, and we did develop more rapidly during that phase than we have before or since. So my own feeling is that PCNs need much more empowerment than they're currently enjoying. Again, my own feeling is that we're largely reactive as PCNs at the moment, notwithstanding COVID. You know, there is the PCN enhanced service, and there are the various other contracts handed down from the centre or the CCG to do with COVID, but our own 5-year strategic plans are very much, you know, a paper exercise at the moment, and I'd really like to see that change.
So again, think about that population health element and the control totals, the system budgets, the theory behind that will enable different ways of doing things. Are you having different conversations locally yet about how best Kent's money might be used to better serve the population, and how primary care might start to see some more of that?
We're having conversations, but haven't actually seen any action yet. And COVID's partly to blame, but even before that, you know, getting a mechanism for moving money around the system so that the money follows the patient, which is totally logical, and you can't really argue against the logic, but you will get pushback from traditional providers, particularly if they are acute trusts, saying, you know, even losing 3% of our income completely destabilizes the entire operation. So even if you can deliver certain services to patients more locally at less cost, we can't afford to let that go. And this is a major problem, I think, moving forward.
Yeah, okay. Yeah, and it's the fundamental barrier, isn't it? That if not everyone can get paid and not everyone can continue to do their jobs, then how does anything develop? So one thing I suppose attached with that whole funding piece and the service development and population health is thinking about outcomes. And I'm sure you'll have a view on how well the NHS has really delivered outcomes for patients in the past. How do you see the measurement of outcomes or the achievement of outcomes changing in a new NHS?
Well, we're doing quite a bit of that already in a way, in that the QOF does look at outcomes in terms of the things that are measurable. So you can see how many of a certain disease category you've got within range, so you know how many people have the right blood pressure, the right HbA1c for their diabetes, etc., etc. Those sorts of outcomes are very much part of the landscape already. The much more difficult outcomes, which are probably more interesting, are the ones that tell us, you know, what sort of quality of life someone's having and how much they're having to go to hospital, how much is being done in the community instead. And people are talking about dashboards and have been for a long time. There are many variables which makes dashboards a bit of a minefield. For instance, the social status and the income of your patient population has a huge effect on what you're going to be able to achieve. But to move towards more meaningful dashboards, to earn autonomy as a PCN by using hospital services less, because you can complete patient journeys within your practice more. I mean, this probably sounds terrible for people who are struggling providing ordinary GMS because of unfilled posts, but nevertheless, if we are serious about local care, that's what we should be aiming at. And I would have thought sequentially to give well-performing PCNs more of the budget based on how much less of the hospital system you're using would be a reasonable thing to try.
And in terms of being able to actually measure that and monitor it, do you think that you have the data available locally in Kent to look at those sorts of things?
We have some data, and data is key to all of this, and it has to be accurate data and it has to be timely data. We have the Kent Care record in Kent, which is helpful, and there are various bits of data coming forward about rates per thousand of use of urgent care and elective care. So there is some data, but it's by no means complete yet.
And what data are there that you'd really love to see? Is it stuff around how you're joining up with the hospital? Is it that social care data to better understand other needs of the population? Are there particular things that you sort of sit down and think it'd be really nice to know this about our patients, our patient list?
Yeah, I think there's a range of data that it will be good to have. Better population profiling would be really helpful. I mean, obviously we know, age, sex profiling, but we don't know everything about how many people are disadvantaged, how many people are, quite frankly, socially isolated. All the social prescribing side of things can be developed more and better. We employ 2 social prescribers, but there's more work to be done there, I think. That would be really helpful. We can get data about how frequently people are using urgent care in the hospital system, and we do, pre-COVID anyway, look at the people who are the heaviest users of urgent care and try to put social prescribing and more medical input into them. We have community MDTs to try to look at all of this and see, are we doing absolutely the best we can for this patient in every aspect, not just the medical model, but the social model, the housing model, everything. So the more complete and holistic the data is, the better job we'll do with our community MDTs. But data is always a challenge. I think it's improving slowly, but we need more of it, and it has to be timely.
Yeah, absolutely. And I think probably everyone in our audience, both NHS and industry, I know we've got quite a lot of NHS colleagues listening in today. I think everyone's sort of familiar with the need to look at variation, and that's a huge priority in many agendas across the NHS. Is it the variation data that you're interested in, or is it more absolute than that?
I think you start from where you are with your population, and we have done sort of comparator data analysis to other towns the same size with the same sort of demographics as Whitstable. Even that isn't totally robust, because the social structure is different in different towns, even if the demography is the same. So I think that there's a range of things that we really need, but to improve on where you are seems a reasonable challenge. To improve compared to some leafy suburb somewhere that's got a nicer infrastructure is perhaps an unfair challenge.
Yeah, okay, that's an interesting perspective, and a couple of the questions that came in from NHS colleagues today were about kind of the sharing of best practice and how do you improve from where you are. How do you approach that if you're looking at a clinical service, whichever it may be? Do you look to other places for ideas of how you do that, and do you have other people coming to you, and then I suppose the follow-up to that is, how do you then share good stuff that you're doing?
Well, happy to take ideas from anywhere in the world, and you know, the concepts of various things that we've tried have certainly not come from England. So it is quite interesting to, you know, be humble and accept that there are, you know, there are good things happening all over the place if only you can find them, and also to publish what you are doing if someone will take it for publication, and to share. I mean, before COVID, we've had a constant stream of visitors, and that's been really good because you see what you're doing through the lens of someone else's experience, and that's interesting in itself. So it's a two-way thing when visitors come. So I think one should always be on the lookout for better ways of doing things. The principle we work by is to try and provide high quality GMS alongside as much integrated health and social care as possible. It always struck me as very odd that we were all medical students as one tribe, and then we qualified and we became two tribes. There was the hospital tribe and the GP tribe. And why is that? You know, a lot of GPs have got skills which could take a lot of hospital work out into general practice and give them added job satisfaction. It also means if you have a group of gypsies or jippers in your practice, you can upskill each other as well, and the whole thing becomes a learning environment, which is great. So I think integration is my watchword. It has been for a couple of decades now, and it does seem to be something which is attractive to patients, and it also attracts clinical colleagues to come and work in Whitstable. We never had any unfilled posts, and in fact, for most clinical posts, we have a waiting list. So
Wow.
that was unexpected benefit of doing things slightly differently.
Yeah, absolutely. That's fantastic to hear. Just following up quickly there, you're talking about your population locally. How engaged are your local population, your citizens, in the development of the PCN, new services, etc.?
We've got pretty good buy-in, actually. I'm pleased to say, and we've got the usual patient participation group. What we've also got, which is slightly more unusual, is the Friends of Whitstable Healthcare registered charity, and that's a wonderful symbiosis. They run a cafe in our main building, Estuary Medical Centre, and which is great for patients, but it's also good for recruitment. And they fundraise for equipment, and I would, you know, like to, you know, pay them a debt of gratitude. You know, without their help, we possibly wouldn't have bought the X-ray equipment. We wouldn't have bought £300,000 worth of ophthalmology equipment. They've just recently bought us our third ultrasound machine. It's marvelous, you know. So there's very much a true partnership with patients. And we use the PPG to float ideas. You know, if we're thinking of developing, I suppose the most recent was a wet AMD clinic, Lucentis injections and Eylea injections for people with wet AMD. You know, do you think there's a need for this? Would you like us to develop it? I mean, the answer typically is yes, of course. But it's good to have them as a sounding board. And we use them for development of our patient advice leaflets as well, and other forms of communication. And they really do help with that, because, you know, as a doctor, you might think you're communicating very well, but if you put it in front of a panel of lay people, you actually realize perhaps you could do better.
Yeah, absolutely. Yeah. Yesterday, it was revealed that Virgin have been awarded a significant contract for providing community services just across the Thames from you in Essex. Do you think private providers or private provision will play a greater role in the integrated care landscape?
It's possible, isn't it? I mean, it's you know, politically a minefield, isn't it? I mean, some people like the idea of availability of choice to go to private providers or NHS providers. Other people think it's awful. We actually work with anybody who's prepared to work with us. So I think private providers have a place. With regard to community services, that's another controversy you've touched on there, Tom, because you know, some of us believe that if you're a well-organised PCN, you're much better off employing your own community trust people rather than have them employed by another organisation. And I know several people have tried to do just that. So whether it's Virgin or an NHS community trust, do you want that, or do you want to have the budget and employ them yourself and have them actually genuinely integrated into your team? It's an interesting one.
Yeah, absolutely. A couple of sort of unrelated questions, I suppose, just to sort of cover the ground that we had in mind. Obviously, a lot of our audience are interested in the medicines landscape. As things develop and we're looking at population health and integration, do you expect the role and perception of medicines to change at all in the new NHS?
Well, it's the easiest thing to measure in primary care is what drugs you're prescribing and how much it's costing. And I think we're all acutely aware that we don't really want to be an outlier on the expensive side of things. So I think there's been it's a well-trodden path to be as careful as you can to prescribe clinically effective, cost-effective medication. And there have been various schemes over the years to incentivize general practices and now PCNs to be just that, to be cost-effective and clinically effective. What's more difficult is judging the outcome of choosing one drug over its competitor in terms of use of secondary care, morbidity and mortality. And because there are so many other variables, that's a really hard one. But I think that the emphasis on cost-effective prescribing will never go away, and we're all very well aware of that. And we personally, at our PCN, we employ 2 pharmacists and 1 pharmacy technician to help us be as effective as possible in that respect.
And could you just expand a bit more in terms of those pharmacists on kind of what their jobs look like? Is it about just keeping on top of reviews and making sure people are getting the right things, or are they doing more besides that?
Yeah, I mean, they are doing reviews. Of course, they're also dispensing advice to patients who appear to be outliers in the use of, for instance, inhalers. So there is a bit of a clinical role there as well. But they support the lead GP for medicines with regard to evaluating new medications and new products, evaluating NICE guidelines that actually refer to changes in medication. So they're part doing reviews, but part of the mechanism for making sure we're as effective as we can be and as up to date as we can be with our prescribing.
Yeah, okay. And as I suppose the pharmacists bed themselves into primary care and themselves sort of skill up and improve their or broaden their own clinical education, do you see that there's any likelihood that sort of more hospital medicines, as it were, might move into primary care?
Well, I'll probably get shot by some of my colleagues who are listening, but my response to that is I hope so. We're having discussions with the rheumatology department at the moment about doing infusion work in primary care. I don't see why that shouldn't happen. If people have the capability and the estate, in other words, the rooms to have someone doing infusions, it would seem a natural next step to me. And I'm back to my sort of principle of integration where possible. Why should someone have to go to hospital for an infusion when it can be done in a practice if the practice is willing and appropriately remunerated for that? So yes, I mean there will be a gradual move into primary care. On the acute side, we do the entire DVT pathway, including looking for underlying causes. So all the anticoagulant prescribing happens in a primary care setting. We don't bother the hematology department unless it's a very complex case. So both on the elective and the non-elective side, primary care can do more if it has enthusiasm and the personnel to do that. I do recognise this is not for everybody. Some people are struggling to get day-to-day GMS done because of all sorts of constraints, and they have my entire sympathy. But for those of us that want to move forward, it would be great to be able to do so.
Yeah, absolutely. Yeah, and that, it's a very important consideration, isn't it? That there's all sorts of pressures. I mean, obviously those pressures are one thing. In terms of thinking about that move of maybe more specialised care in various different ways to primary care, you obviously feel quite comfortable that you can accommodate that. What might some of the apprehensions be? If there was a systemic desire to move infusions into primary community settings, what are the apprehensions that might exist within primary care about taking those sorts of things on?
I think there are several. I mean, first of all, it's sheer workload. Can you take something else on, or would you rather not do that? Thank you very much. The other one is remuneration. I mean, it's going to be thrown into what is sometimes referred to as the dustbin of general practice. Chuck everything in the dustbin and it gets dealt with. That's a rather rude expression, but you've probably heard it before. Or is this considered, extra work that ought to be remunerated appropriately and probably can be done at less than the cost of going to hospital for it? You also need the estate. It's not a very sexy subject, but the more you take on, including the ARRS roles, you've got to put them somewhere. So more recognition that if general practice is to provide local care, it needs better estate in order to do that, and that's really important.
So estate's a really good one. I hadn't sort of anticipated that coming up, but thinking about that additional need, and in other countries and even in private settings in this country, healthcare is literally delivered in office blocks and things like that. Do you imagine kind of a more responsive, if that's the right word, use of different types of estate within a place?
I think it has to be fit for purpose, and obviously a clinical room looks different from an office in that it's got a sink in it and it's got enough space for a couch, a computer, and the sink, etc. So it has to be good estate, not just any old estate. And it's difficult for general practice to develop anything that's not used for GMS at the moment, because GMS estate, if everything works correctly, one gets notional rent for that. But if you develop extra rooms for basically community contracts, you're on your own. You're in the real world of business, in that you will have to get a mortgage and then attract community contracts to pay for the mortgage, the staff, the service, and hopefully give you a margin to grow your practice some more. That's the world I've lived with for quite a long time now, but I tend to lose the audience when I get to this part of the talk, because people are not really keen on taking that risk for a contract that may be 5 years long, with the promise of a renewal, but you can't be certain. So I understand the reluctance in colleagues who love the idea of providing everything I've talked about already, but are very nervous about the potential downfall if the CCG or the ICS, as will be, suddenly take away the contract.
Yeah, absolutely. Yeah, and it is those practical things that get in the way, isn't it? And not that they're small practical things, but fundamentally, if you have nowhere to operate, or you are going to be operating at risk, then where's the incentive? So just one more question really is about whether you see healthcare industries playing a role in supporting the future health and social care landscape.
Can you just define healthcare industries for me?
Well, a lot of our audience are pharmaceutical companies, medical device, medical technologies. Yeah.
Sure. Yes, I think there's potentially a role there, most definitely, and can give you practical examples of that. I mean, if a pharma company has a drug in an area of interest, the idea of helping set up training to develop community pathways is of fantastic value, and that they already do that to an extent by bringing in expert speakers who have already got experience of community pathways to share those with new people who want to do the same. I think there's that sort of input can be of fantastic value, and we have had expert speakers sponsored by pharma coming into Whitstable, and it's been very helpful. If you look at equipment manufacturers. If you're thinking of setting up a service, for instance, cataract surgery, it may well be that the maker of a lens will be prepared to give you some equipment in return for you ordering lenses from them. These sorts of things happen. So there's definitely partnerships which are of value, and they can be explored and improved.
Are there any areas of what you're doing or thinking about at the moment where maybe you could see a role for industry support that you haven't previously explored?
We are keen to develop some scoping services in-house, and any help with developing scoping services would be useful. I have to say at the moment the block is actually getting a contract to do that, even though there's huge waiting lists locally and an unmet need, and we could do it at less than tariff. But that's perhaps a bit too much detail. But yes, there are areas where industry could certainly help, and we're alive to that.
Yeah, and would you look to industry for sort of providing data and insight in sort of local populations, or that variation data, those sorts of things that we talked about?
We've done that once in the past, population profiling, which was actually of great interest. It would have been nice to have done that maybe every 3 or 5 years, but the industry partner lost interest in doing it, having done it once, which was a shame. But it was a great insight for us. It gave us a lot more information about the activity or lack of activity of a lot of our population, and how many people lived alone, how many people had a car, how many people didn't. So that was actually quite interesting.
Yeah, fantastic. And I suppose that sort of stuff is increasingly important. So thanks very much, John, for your time today. We're going to have to draw to a close there, but fantastic to have a chat with you as always, and appreciate it's a really chaotic time. So very much appreciate you joining us this afternoon. For our audience out there, thank you for joining us. We are going to be back next week. I'll be speaking with, next month, I'll be speaking with Professor Indy Singh, who's the Chief Pharmacist at Birmingham Hospital, about the evolving picture around medicines and specialised commissioning and areas like that. Please follow our LinkedIn page, NHS Whispers, and if you want to get in touch after the event, it's nhsinsights@mtechaccess.co.uk. So thanks again, John. Have a good weekend, and yeah, thank you everybody at home.